Good evening and a very warm welcome to today's webinar, Medication Management in Multiple Sclerosis. We're really delighted tonight. We've got two fabulous presenters for you, Professor Jeannette Lechner Scott, who's presenting from Newcastle, and Jodi Haartsen, presenting from Melbourne. I'm your facilitator, Nicola Graham, and I'm joined by Rachel Morrison from the Pharmacy Guild.
Thank you, Nicola, and thank you everyone for joining us and our speakers to learn about MS and medication tonight. It's really great to see such a huge turnout, and it really highlights the important role that pharmacists play in supporting medication management for people living with MS. I'd like to take the opportunity to thank MSL for making this webinar possible. We are all in for a real treat tonight with these two speakers. Nicola just has some housekeeping to run through and then we'll jump right in.
Beautiful, thanks Rachel. So I just want to quickly run you through the content that you'll enjoy tonight. So Jeannette will be covering the pathophysiology, epidemiology, medications and the method of action of the DMTs. Jodi will cover MS medication management and how as a pharmacist to best support the person with MS. Jodi will also cover safety risks and side effects, which I know is a key area of interest for our attendees tonight. Risk management of MS disease-modifying treatments, MS symptom management, and how on earth you can keep up to date with all this information. And then at the end, Rachel and I will very briefly cover some of the supports and services from our respective organisations. So we like to start all of our programs with an acknowledgement. So we like to acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. And we acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country and respect the cultural authority of the elders in each community. So just a note here about informed choice, and it's my pleasure to introduce our two presenters tonight. So our first presenter is Professor Jeannette Lechner Scott. Jeannette graduated from the University of Heidelberg, where she also completed a PhD in pain pathways. Since arriving in Australia, Jeannette has become the Senior Staff Specialist in the Department of Neurology and Conjoint Professor at the University of Newcastle. Jeannette has established a multidisciplinary MS clinic at the John Hunter Hospital in 2006, and that's actually one of the largest MS clinics in Australia. And she also leads a very productive MS research team at the Hunter Medical Research Institute. And Jeannette Haartsen is Executive Manager at Multiple Sclerosis Limited. Jodi started her career with MS Healthcare and MS Nursing over 20 years ago as part of her nursing career in general neurology, neurosurgery, nursing education and research. And Jodi's roles include MS nurse practitioner and manager of the MS clinic at Eastern Health. She's an MS researcher and an MS educator, and she's a very passionate member of the Global MS Brain Health Steering Committee. She's also got a master's in nursing and in naturopathy.
Thank you for attending this webinar, and I'm quite excited that so many people are interested in the topic of multiple sclerosis, something that I have been involved in for so many years and cared for so many people that have been diagnosed and taking them on the journey through their disease, which is over 20, 30, 40 years in some of the patients. So these are my disclosures. It is quite interesting to see that the prevalence and incidence of MS is steadily increasing. In some countries, substantially so. In other countries, especially in the countries in the northern hemisphere, further away from the equator, and in the southern hemisphere, further away from the equator, that peter a bit out. But in the central districts of the world, the incidence is tremendously increasing. And we have done a study spanning the last 50 years in Newcastle, because we've had incidence and prevalence data collected in 1961, 81, 96, and last in 2011. And in the last 15 years, the incidence and prevalence has doubled in Newcastle. And it is surprisingly to see predominantly young females that are more likely to be diagnosed with the disease. So what is causing multiple sclerosis? We searched far wide and found up to 250 genes now that predispose you to this disease. But it's a number of different genes, and it's not like a autosomal dominant disease or even recessive disease that you have 50% chance if your parent has the disease. It is more like if the general population has 1 in 1,000 and you has a first degree relative, your disease risk is increased to 7 in 1,000. So we assume you have this genetic predisposition, but then an infectious agent or some environmental factors like vitamin D deficiency, lack of sunlight, or obesity in young age, or smoking is triggering and offsetting the disease. During the decades that I've been dealing with MS, the interest and the understanding has shifted. So we always thought it's a demyelinating disease that is involving particularly T cells. Well, we know that the axons are affected as much, and it's now shifting to more B cells. So if you can see here, T cells imbalance, more activating T cells, the Th17 in the balance than the regulatory B cells, and the regulatory T cells. And the B cells are only there to present the antigen and have some antibodies, which we're testing in the CSF, which are the oligoclonal bands. But now we know that there is a far more diverse interaction between T and B cells, and the role of the B cells has increased significantly, particularly because of the new treatments that we have found. So there is a substantial introduction of an antigen to the T cells, and it's not only regulatory T cells that are diminished, but also regulatory B cells that are diminished, and the pro-inflammatory macrophages, B cells and T cells are overwhelming in people with MS. If we look a bit closer into the genes that are predisposing to MS, it is quite interesting to see if we compare all these gene-associated studies, genome-wide associated studies that we have done from different disease groups. Here is multiple sclerosis, very close to it is celiac disease, rheumatoid arthritis, lupus. If you look which genes are affected, it is predominantly T cells activation, B cell activation, but not original brain genes. So nothing here which we find associated to Alzheimer and restless legs, but not in. So this is the proof that it is an outside-in disease. It's an activated immune system that causes the disease, and it's not originating from the brain itself. With this knowledge, we have guided the therapies. So just a short overview of what we see as a clinical picture. This very much depends where we find the lesions. So there's a random distribution where the lesion will be and what the first symptom will be. It could be an optic neuritis, so visual impairment. It could be double vision. It can be sensory disturbance if it's in the spinal cord. Something that is often overlooked is cognitive impairment, or bladder and bowel problems. It's rarely associated as a first symptom, but it's definitely all there if you have the disease for 20 years. And these are classical images of MS with subcortical lesions here with U fibers, periventricular, these dorsal fingers. And if you see that and see lesions in the spine, you can make the diagnosis on the MRI alone. Now, over the 25 years that I've been dealing with multiple sclerosis, there is an explosion of new therapies. So I had patients lining up for the pivotal trials of beta interferon. Now with the new trials that we're conducting, it's very difficult to convince a patient why they should move from one very good treatment to a not yet tested treatment. So the first treatment that was introduced was beta interferon and then glatiramer acetate. They have the major disadvantage that they are injections. Revolution came in with oral therapies, but the probably more effective ones are the monoclonal antibodies. And I go into that in detail from now on. I must admit, I've adapted the slides a bit from your handouts because some of these have been, coming on PBS only very recently. So ofatumumab is not yet an approved therapy, but will be very soon. So Jodi and me have been working in the MS space registry for quite some time. This is a worldwide registry organized from Melbourne, which includes 67,000, or I think it's now 85,000 patients all over the world. With this massive amount of patients, we can look over a long time, we can compare treatment and we can compare outcome, which is not possible in a single prospective funded study. So this has only recently been published, but summarize what our experience is. It is most important to treat with high efficacy treatment early on. And this is compared between the first 4 to 6 years in their disease diagnosis or onset of disease. Often we don't see the patient until they're already 6 years in the disease course. I have just diagnosed a patient last week. She had her baby 6 years ago. Postpartum, she developed some numbness in her right hand. She thought, oh, it's just, just postpartum. It's, I had a baby, I have to lift her. Now she had an optic neuritis. We've done the MRI. The MRI shows a C6 lesion. Clearly that was her first symptom. So this study shows quite clearly that the benefit that you get if you start early with very efficacious treatment, rather than once you had the disease for 10 years and you had a couple of relapses that are not controlled with mild efficacy or lower efficacy treatment, that gap is not to be caught up with. So treatment regime. So in Germany or in other European countries, they still have the first line, second line, third line treatments. And most, even in America, the injectables are still first line treatment. It's safe, apparently less side effects, and only move on to more efficacious treatment when a further relapse or disease activity happens. So that's the escalation therapy. There is arguments for that because you don't want to immune suppress everybody when they had their first symptom. But as we've just seen, we're missing out on treating or preventing disability that we're never catching up later. If we start with high efficacy treatment like natalizumab or fingolimod, we have the problem as soon as you stop it, the disease is coming back up. We'll talk about all the side effects, or Jodi will talk about all the side effects of our high efficacy therapies, which are severe immunosuppression. Even if you do induction therapy treatment that you only need to give it a pulse with alemtuzumab or cladribine, then there's still long-term side effects that we experience and we need to monitor for. And then there is the benign course. So 30% of our OSLONG data, so we took patients with CIS, first clinical isolated syndrome, and observed them over 15 years. And a third did never develop full-blown MS. So you would treat these people based on their MRI activity, and 15 years there wouldn't be any second event. So this is all what you need to discuss with the patient in the first diagnosis. You need to look at the MRI. We're basing a lot of our decisions on MRI and MRI activity and come to a conclusion. So going through the different categories, the injectables, the beta interferon comes in 4 different forms. There is the oldest is the betaferon, and they have still not, as far as I'm aware, improved their injector. It's quite clunky. Rebif looked at the time a bit more fuzzy, more jazzy with the injector, and you can leave it out next to your bed and inject 3 times a week. This is what you have to do with betaferon and Rebif. Avonex is an injection in the muscle once a week. You would think that this has less side effect, but unfortunately, with the less frequency of injection, they do get more flu-like symptom than the more regular ones. Copaxone is a completely different mode of action, maybe better tolerated and completely utterly safe if you want to fall pregnant. Plecredy is a slow release beta interferon subcut, only every 2 weeks to inject. So here it's a very busy slide, but this is basically in one slide the pathophysiology of MS and where we think that beta interferon is acting. So I've told you that it is an outside-in disease. So this is the blood, yeah. So B cells and T cells, so the pro-inflammatory T cells get activated, and because they get activated, they can break through the blood-brain barrier. They need MMP 2 and 9, which is making the gaps here in the blood-brain barrier bigger, and they alternate also the ICAM and VCAM. So beta interferon has shown to be effective to reduce this breakdown of blood-brain barrier, has been shown to reduce the presentation of VCAM and ICAM. But also here in the periphery has shown to increase the anti-inflammatory cytokines and decrease interferon gamma and TNF, which is pro-inflammatory cytokines. Once the T cells and B cells will pass the blood-brain barrier, B cells set up underneath the meninges in B cell follicles, and when the blood-brain barrier is closed again, this is the more progressive phase of multiple sclerosis, where we don't see gadolinium enhancing lesions and acute relapses, but there is still these B cell follicles in smoldering activity, and even in chronic 20, 30-year disease patients, you see that their lesions show an inflammatory rim. But these are the side effects from 20 years injections. You get this lipoatrophy. Beta interferon here all these dimples, not very good for bikini figure. These are subcutaneous necrosis that you get with beta interferon injections. And unfortunately, with the 2-weekly injection, you actually get like an orange size erythema often. So quite often patients just can't find, once they've been on beta interferon for several years, they can't find a spot where they can inject anymore. And they're dying to go on tablets. So when Gilenya was introduced, the uptake was really very high. So it's a once daily tablet with Gilenya. Tecfidera is twice daily. Maycent is recently, Siponimod recently introduced for secondary progressive patients. Aubagio is also a once daily dose, and cladribine is a tablet course 5 days in a row. Then in week 5 again, 5 days in a row. Then the following year, and the studies have shown that the disease is stabilized in 44% of at least for 2 years, and the disease stabilization is maintained for at least 4 years. We haven't got larger studies. We're doing one at the moment that looks at least 6 years, and hopefully we will get funding to push that out to longer. So how does Siponimod, Fingolimod, or now Ozanimod has been approved and can be prescribed work? These are S1P1 receptor inhibitor. This is receptors that sit on the T cells, and these drugs stop them from egressing from the lymph nodes. It's actually quite a substantial difference between Fingolimod and Siponimod. Siponimod and Ozanimod were meant to be more specific than Fingolimod because they specifically only do the 1 and 5. These are the ones that you find more commonly in the microglia and the neurons, whereas Fingolimod is also 2 and 3, and you see more these receptors also on endothelial. So what we see in patients is that they get an increase in blood pressure over the years. But my main concern with this treatment is what I've seen is a substantial increase in squamous cell carcinoma and basal cell carcinoma. So patients that have been on it for a decade need to really be screening very clearly on a regular basis. So this is comparing Ozanimod, which is the new drug, versus Fingolimod, and their rate of cardiac abnormalities. So the introduction of Fingolimod or Siponimod has the risk of causing AF block, so cardiac block. We haven't ever seen it, but we are meant to monitor patients for at least 8 hours after the first dose, because you do see a significant bradycardia. So a patient who has a slow heart rate should never go on these drugs. I have not ever put anyone on these drugs that has any cardiac history or hypertension. There's other alternatives that don't put our patients at risk. You also see, because of this endothelial effect of Fingolimod, macular edema, which we monitor for with OCT, ocular computed tomography. In particular, diabetic patients do develop macular edema, so I wouldn't recommend it for them. 2 other oral treatments are antimetabolites. So teriflunomide, both are only antimetabolites of activated T and B cells, and this is because this enzyme is more present in the T and B cells, and this is the enzyme that is inhibited by teriflunomide. Cladribine, this is the short course treatment, 5 days, then week 5 days, and then the following year, has been known to you as a subcut injection probably for leukemia, but this is an oral version specifically tested for MS patients. And again, it is reducing specifically T and B cells, activated T and B cells, because the enzyme that you require to activate cladribine is not present in the other cells. Dimethyl fumarate, we don't really know how it works, but we assume that it's affecting on the nuclear red cell F2 kappa in the cell nucleus, and produces an anti-inflammatory and antioxidant activity. We could actually show even in MRS, in spectroscopy, that it does increase GSH in the brain. And this is, the GSH is something that we have shown that is different between MS patients and healthy controls. It is a very effective treating. It isn't working immediately. It takes a while to work to reduce the inflammation. Unfortunately, a hell of a lot of patients don't tolerate very well because they get nausea, they get hot flushes, which you can reduce with aspirin. We've slowly introduced this with the low dose and then slowly going up. Then patients tolerate it better. Once they're on it, it's really working quite well for a long time and has definitely a protective, neuroprotective phase. It is also the only oral treatment that has a good pregnancy registry with good data that it doesn't really harm the fetus if you continue taking it when you plan to fall pregnant. We sort of moved the way of stopping treatments, although I know it's recommended to not fall pregnant on any of the treatments apart from the injectables. But we don't want patients to wait too long to fall pregnant and then get relapses because they've been off treatment. So we now try to start them on treatments that they can fall pregnant on, and dimethyl fumarate is one of these treatments. Moving on, not want to extend it too long, monoclonal antibodies. So I told you initially how important the B cells are, and this is the new array of treatment. B cells receptors are many. There is 2 different ones that go on CD20, rituximab, which we had for a long time, and ocrelizumab, which has been more recent introduced. It's 6 months infusions, and there is quite a number of new B cell therapies who are in the making or currently in clinical trials and will be approved. But it does matter which B cells you stop, and atacicept, which affects APRIL and TACI, was trialed and actually activates the disease. So we need to be careful where we interfere in the whole balance act of immune cells in the brain. Alemtuzumab is a monoclonal antibody to CD52. This is similar to cladribine and induction therapy, 5 days of infusion, and then the following year again. And it's a very, very effective treatment, but it's quite risky. The more it's used, the more infusion reactions are shown. Pulmonary alveolar has been hemorrhage. Alveolar hemorrhage has been described in quite a number of cases by now. you really wipe out all B and T cells, and it's not something that we currently recommend during the COVID-19 pandemic. Natalizumab, I would say, is one of our, or the most effective therapy. It stops any B or T cells to go into the brain because it blocks the alpha-4 intercam on the VCAM. So that is wonderful for MS, but it's not so good if you have a viral infection like JC virus that has a mutation. Usually you live quite happily with it. 50% of the population carry this virus excreted in the urine. Only if you have a mutation in that virus, it goes into the brain. If you're then on immune suppressant, in particular an immune suppressant that doesn't allow any monitoring in the brain of T and B cells, then you have a disease that is caused progressive multifocal leukoencephalopathy, for which we have no treatment, and is in HIV patients was always lethal. In MS patients, not always, but it's always bad news. So comparing cladribine, which induction therapy, these 2 short courses, year 1, year 2, to alemtuzumab, because they are quite similar in idea. The problem with alemtuzumab is you stop all cells, and then you have a rebound of the B cells. This rebound of the B cells is big after the first, then you get the second dose, and it's even bigger after that. So year 3 is when we see all the autoimmune diseases. I told you that the genetic predisposition for MS is similar to a lot of other autoimmune diseases. For example, Hashimoto's. So a lot of our patients have the same genes to develop Hashimoto as they do have MS. And if you cure MS with alemtuzumab because you reduce their B memory cells about this disease, then they suddenly start having other autoimmune diseases, and thyroiditis is one. It could be more that can be treated, but immune thrombocytopenia is one, and also kidney disease, antiglomerular membrane anti-GBM nephropathy is another quite dangerous complication of alemtuzumab. But in our cohort, it's unfortunately 30% that develop autoimmune thyroiditis, and I don't think that is such a mild disease, and my patients struggle with it. If you compare that to cladribine, yes, there is a sort of up and down as well, but it doesn't overshoot like alemtuzumab does. So this is a picture of progressive multifocal leukoencephalopathy. So you can see that it's easily, it's quite difficult to differentiate it from an MS lesion. This is Graves' disease, thyroid disease, and this is anti-GBM glomerulonephritis. Infusion-related side effects, very common in alemtuzumab, but you can get it in all monoclonal antibodies. And of course, if you immune suppress patients, varicella is very common, zoster. We always check our patients that they are immune and try to give them a booster. Most of the orals can cause a liver abnormality, and that is an ITP, and they can get septic. So what we strive for is neither, no evidence of disease activity. So they shouldn't have any relapse, they shouldn't have any new lesions, and we monitor them on MRI once a year, and they shouldn't have any disability progression. So it's neither 3. So I've listed here, including the latest data of Asclepios, which has only been coming out in August this year. And you can see Opera was the ocrelizumab study, Clarity was the cladribine, Asclepios was the new B-cell therapy that isn't yet available, care is lemtuzumab, Afirmis, natalizumab, fingolimod, beta interferon, tecfidera, and teriflunomide. These are the clinical trials NADA3 data. I'm not saying which one is the best or whatever, but that's the data.
And thanks to Jeannette, because covering the landscape of MS treatments, I think we're up to about 15 or 16 now, is such a complex thing to reduce into such a short space of time. And certainly decision making in MS treatment is something that is that would take another hour, I think, to talk about in terms of the way that decision making is approached in MS treatment, because there are so many variables to consider when you think about which is the right drug for the right person at the right time, and it's an incredibly complex decision making tree in the landscape that we have of MS treatments. But my amazing job as a nurse practitioner and as a nurse was as to talk about the lived experience of these patients and helping them, I guess, with the medication management and supporting them through that. And so we all know the value of a team, but it is the cornerstone of medication management. And I think that a highly effective team really empowers the person to own the medication themselves. MS is a disease of young people, and so we do know that they often have the capabilities to be able to really be informed, to be activated. And when you can have a team that's highly functioning, that understands their roles, that works together, we all know in healthcare the benefit of a great team. So I just wanted to bring it back to baseline to really help to really centre what we're talking about and how important integrating management is. One of the things in my 20 years of nursing, when I saw all these treatments come and go, one of the things that I really that became such a reality to me as more and more new treatments emerged was that everybody had many questions, but they all needed to be answered over time, and they were never usually able to be answered at once. And the important thing was to start with what mattered to me first. I also understood that it wasn't my job to answer all the questions. I didn't need to, because other people could actually do that as well. But certainly, I guess this slide, and there's probably, if I sat down and thought about it for another week and got, there would probably be even more questions that came up. And that the fascinating thing was that for each different person, the initial what matters to me was often not what I expected. And was often really relevant to what was going on with their lives. If a young woman was considering pregnancy, the medication choice and what was to be considered in helping support her ownership of medication management was really going to be around what treatments are good for pregnancy, how's it going to affect it, what happens if she falls pregnant on the medication. And so, but for a man who gets diagnosed, they might have a lot more about, well, is this going to affect my job? How am I going to get there? And will I feel sick? So everyone has a different range of questions, and we all need to be a team to work together to answer those questions as well too. One of the things that I guess is on everybody's lips but it also helps to frame some of the information I'm going to talk about, side effects, is the impact of COVID-19. To the absolute credit of the neurologists community, the global community in MS, we really have so quickly garnered some really informative data that we've been able to use to really support people. But for people living with MS, there was the first few months were just so filled with uncertainty and fear that was well understood by the neurologists. And it actually, there was the information sharing channels were so quick. Even on Twitter, people were making information available right from really early, in the early stages. The Italian neurologists, the Spanish neurologists, they were really trying to get that data out there. And fortunately, the early data suggests that there isn't any risk for people on MS on the immunosuppressive medications in MS. The risk factors for people mirrored the global risk factors, including such things as age, obesity, other comorbidities. For people with MS, it was more advanced disease as well. So risk factors, particularly for doing worse, but also for being at risk of the infection. So anti-CD20 treatments slightly increased the risk of worse outcomes for people with MS, but it wasn't significant. There was some suggestion in the early data that IV methylpred courses may increase the risk. So that's sort of a watch and wait, because that's the mainstay of treating relapses in MS. And really importantly, the degree of lymphopenia, which is a common in these immunosuppressive treatments, hasn't appeared to be emerging as unrelated to risk or outcome. So these were extremely important data for people in how we treat MS, but really in trying to interpret that data for people living to ease that uncertainty and fear. Other things emerged: delayed access to services, delays to treatments, increased social isolation, and even medication shortages, which is unheard of in Australia, was something that was, all these were new, and they all required a tripling of the effort of that team and the communication within that as well too. And it's, you know, I hear many more stories of good team action and team activities than I do less ones. So that's really good information to know. But harnessing again on communication, I guess that was sort of that was in my nursing role. Understanding the right amount of information for the person at the right time was a really significant part of my role, and health literacy was important. And I guess one of the key messages of health literacy is you don't know by looking at someone, but they do know that health literacy is associated with poor medication reconciliation, poor knowledge of drug indications, poor understanding of instructions and dosing. That the relationship with health literacy and adherence is complicated, because it seems people with high adherence do have a tendency also to, with high health literacy, do have a tendency to be non-adherent, equitable to people with low literacy. So it's not as well correlated, that relationship. But nonetheless, it's certainly, in terms of enabling people with medication management and MS, understanding their health literacy, and as I'm sure every pharmacist knows this information incredibly well. Support measures include, there is an interesting approach to health literacy, which is the universal precautions, which assumes that everybody needs it to be kept simple, which is a good one, I think. Regular brown bag medication reviews is something that I know when we sent people away with a complex medication regime, that either the hospital pharmacist or the local pharmacist was going to be really important in that medication reconciliation and understanding and supporting the information that I had provided. Keeping it simple, reducing the complexity of environments is something that where I could minimise anxiety by making the environment friendly to people. By, you know, we all have that anxiety of where am I going to go, what is it going to look like, which pharmacy am I going to go to, will I be able to get, you know, for people with more disabilities, will be able to, you know, access within the pharmacy. So just considering those, the literacy of the organisation as much as the personal literacy really can again empower people to have effective medication management. Frequent teach back and the more aids that you have available to increase people's understanding, the more likelihood you are to have success. In talking, just reiterating health literate systems, because I think it's something that we often forget. I've put a picture of Heathrow here because I remember turning up to Heathrow when they changed it, and everything had huge signs and big colours and simple instructions, and I thought, here is a good example of a literate system. It's simple to follow, it's easy, it's logical, and even something as complicated as Heathrow Airport was really simplified. And you know, for people who had poor vision, all of a sudden these huge signs were there. So often when I'm thinking about how literate is the system and the environment that I'm working with, I think about how simplified Heathrow was, and I think the Royal Children's have done a great job in that as well too. So when I move on to talking about safety risks, and Jeanette's covered some of these really beautifully. So what I've done is provided a table here. So hopefully, should have told you that before you all took notes. But these statistics that I've provided are the base statistics that you will find available in any prescribing information. And so what we know is that that long-term safety risks are, to a degree, as good as long-term pharmacovigilance. And I think we're all familiar with the gaps in pharmacovigilance. One of the databases that Jeannette talked about, MS Base, has really put in efforts, and other global databases have put in efforts to be able to make sure that we do long-term, over 10 or 15 years, monitor safety, because relying on usual pharmacovigilance methods really don't give you as much of a good perspective on degrees of how much of how often these are occurring. And the Australian MS community has really, nurses and the neurologists have really put in a lot of effort to maintain these safety registries to give us more up-to-date information, and then that usually is fed into publications, but often disseminated in other different sources, which I'll talk about in staying up to date. So what I've done is highlighted, when we talk about the medication, some of the more common risks, and certainly ones that are attached to a risk management program. So things that we can prevent if we put in place good risk management. And risk management is as much about the team and having familiarity of these more common occurrences, but knowing that there's rare ones. And you could summarise it quite nicely. And I'm going to keep with a summary to keep on track with time, and also because Jeannette has covered some of these. You could summarise these into risks of infections, and most of those are classified as, it's far more common to have, those rare risks are more opportunistic infections such as herpes virus and the disease Jeannette mentioned called progressive multifocal leukoencephalopathy. Now, that because of the disastrous nature of that disease, it's something that we put a lot of effort into ensuring we've got good risk management programs. And any MS clinic would give you a comprehensive overview of the risk management program, and as does the prescribing information, gives guidelines that most MS clinics stick to those sorts of risk management programs. Jeannette covered the AV block risk in people on Gilenya, on fingolimod, and siponimod is going to be, and all the S1P receptors are going to have the same sort of cardiac risk, or those variances. There is variances between them. Monitoring hepatic function and liver injuries is something that we were vigilant about when we use these treatments as well too. And many of the treatments come with a degree of risk for liver injury. So it's kind of easy to kind of think infections, liver injury. And then there's the great unknown, because a lot of the treatments really haven't been around long enough to give us a true indication of whether there's going to be a risk of malignancies. And so we're very proactive in risk management to make sure that patients regularly do get the checks that they can do, the preventative checks, regular cervical screens, regular prostate checks, breast screens, whatever, all the relevant checks that can be done, skin checks in particular, because there was a slightly increased risk of basal cell carcinomas on people on Gilenya, and that emerged as a risk over time rather than something that we understood early when fingolimod became available in 2010. So that covers the oral treatments, and then we move on to the IV treatments, and these include Tysabri, Ocrevus, Lemtrada, and very rarely used mitoxantrone was a chemotherapy that we really haven't been. It did come with some significant cardiotoxic and leukemia side effects, so I haven't seen it used for a long time, but it's still sort of considered one of the treatments available for MS, such as included is HSCT. But these other treatments are much more common, and again, the huge risk on Tysabri treatment is PML, and the risk rate is a variable depending on a number of different factors. There are three main ones: the JCV status, the time on treatment, and whether there's been previous immunosuppression. I guess in relation to that, because of life happens, most people with MS will have probably at least 2 or 3 different medication changes over time. That's becoming less so as the treatment efficacy have got better and treatment targets and treatment changes. But certainly over the last 10 years, it was not uncommon for people to sort of have have 2 or 3 different treatments. Pregnancy often interrupts treatments, and so we need to work the treatments around pregnancy risk as well too. So these sorts of things, as I said, the red ones are the ones which I guess are more severe and risk managed more carefully. In terms of everyday living, that was probably what I spent a lot of time talking to. People were variable in what was more important to them, the side effects or the safety risks. Some people really wanted to know about how will this impact me in my everyday living. Other people were more concerned about the long-term safety risks, and that tended to change over time as well too. Again, I've just highlighted the more common ones that were more part of my everyday life. And so cladribine, for instance, otherwise known as Mavenclad, you'll see has associated nausea, arthralgia, headache, back pain. They're all listed as relatively common, but in fact, most people, the majority of people, tolerate cladribine exceptionally well, and they were really unusual in everyday clinical practice. Saponamide is still really relatively new, and I suspect that side effects will be the same as fingolimod, but we haven't seen it. It's only just become available in the PBS, so it's not something that, but as I said, given its mode of action, it's likely to be similar. And so headache and back pain, less than 20%, but they were something to be aware of. And depression and fatigue was not well reported, but we do know that there was a small percentage of people who really just became depressed on Gilenya. And that was another thing that happened that's not sort of well documented, but most neurologists will reflect that experience and say, yeah, that's a thing. And we know that that's a thing, although it's not well reported because it was something that emerged over time. Because of it, it's really actually quite uncommon. And then moving on to teriflutamide, hair loss and diarrhea can be side effects of those that people, hair loss really was something that was short term and resolved after 3 months. And diarrhea, in some cases of people on Aubagio, that was very persistent and needed its treatment change because of that. But again, it was unusual. Jeannette covered a bit of the problems with dimethyl fumarate. Sorry, I've not gone in order, but they were really quite common, and these everyday living side effects. In the case of dimethyl fumarate, it was one of the reasons. It was a high reason for discontinuation compared to the other oral treatments, which had a very low rate of discontinuation related to side effects. In terms of everyday living, safety risks were efficacy were a much higher reason for switching medications. And then I've covered, infusion reactions were the most common in ocrelizumab, much higher in alemtuzumab. Infusion reactions usually are managed quite effectively with the PPI, some antihistamines and paracetamol. They were regularly managed also with antivirals to prevent herpes reinfections as well too. So really more common in ocrelizumab and alemtuzumab, less so in Tysabri, that very significantly less so. And Tysabri is probably one of the most well tolerated medications of all time. And then pulse methylprednisolone, probably most pharmacists would be familiar with that. So for the sake of time, I will move on from that. Interferons and glatiramer acetate, which Jeannette covered with the side effect pictures, also came with flu-like symptoms, depression, injection site reactions, and immediate post-reactions. I won't go much into those because really they're not commonly used anymore. It's not, most patients are on the higher efficacy treatments now. There's still some people on these treatments, so it's worthwhile knowing about them because they do actually impact people. Their safety profile is very low. These are all rare safety side effects on the blue side, on the blue, but in the green, the side effects of everyday living were so common and people really didn't tolerate these medications well. So I think most of us in MS treatment were overjoyed when the treatments became better and improved. Risk management is comprehensive: before treatment, throughout treatment, at treatment, and at treatment switches and long term. There's a whole, as you can see, this is just a simplified table of all the different requirements in risk management, and I think it's great to have oversight of that because, as I said, it is such a team effort. And again, infusion reactions, I just put these there because they are often, particularly for pharmacists, are often really helpful and supportive. They certainly were and continue to be in my practice, incredibly supportive in helping to manage infusion related reactions. I don't want to forget MS symptom management. because it's such an important part of MS medication management. But again, it takes probably 3 hours to go through all of these. So I've just listed a table there for your usage so that people are able to sort of scan over what are our common treatments for the different MS symptom managements. One of the key messages, I think, is that there are very few of them interact. In fact, I can't think of any of them that interact with the treatments, with the MS disease modifying treatments. So while, as I said, I wanted to include them to raise awareness of the importance of symptom management and how, particularly for local pharmacists, this is such a key issue. And if anyone ever wants to talk to me, I'd love to talk about it. In terms of keeping up to date, COVID's certainly given us a whole new world to how to keep up to date, and through that I've discovered some more little gems. Twitter became my best friend in terms of garnering information. I worked out very quickly which were neurologists to follow and which organisations to follow that were going to keep me up to date. Up to date in itself is a good resource. I didn't include pharmacy resources because I'm sure that you all have your own favourites, and there were ones that I typically use as a nurse practitioner, but I think given that the majority of people were pharmacists in the audience, I thought I'd leave that up to you, so how we do it in MS. There's a couple of neurologist-driven organisations that really do work hard to keep people up to date, and that's the International Women in MS, which is a newly formed organisation, but they offer free webinars and they're very passionate about relaying information about how to keep up to date with what's going on in MS. And a UK team at Barts are also very passionate about making sure that they keep people up to date. There's a small organisation called MS Translate who also work hard to do that. There's sort of 3 organisations that I'm aware of in Australia. And then MS Australia, MS Trust in the UK, all the peak body organisations were also really do try and make sure that new risks are identified and kept up to date. That people are kept up to date with the latest risk stratification and the latest safety data of the MS treatments as more emerges over time from the efforts of multiple efforts of pharmacovigilance coming together. So I feel like I've gone over that very quickly, but I am now exactly on time at 8 o'clock.
You are a legend, Jodi. Thank you very much. So the question I've had is for Jeannette, and let me just bring that question up. So it's from Damien, and Damien's asking about vaccine administration timing, e.g. seasonal flu vax, in those patients being treated with IV monoclonal antibody therapy, for example, Ocrevus. When would you time that vaccine? So he says, I'm aware non-Lyme vax should be given a minimum of 6/52 before treatment. Live attenuated vax is contraindicated during treatment or until B cell repletion after discontinuation of therapy, but keen to hear Jeanette's thoughts on this. So thanks for that question, Damien.
Yes, a very important question. So we recommend flu vaccination for all of our patients, even if they are immune compromised, or even more so when they're immunocompromised. We're very keen, and Jodi alluded to that we'd screen our patients before and see that they have had all their usual vaccinations and catch up with that before we start immunosuppression, especially if it's involving live vaccine like varicella. The timing, I know there is a recommendation for it, but once you had several doses of ocrelizumab, I think it's irrelevant when you actually time it and if you use it 6 weeks before, because the B cell depletion is way longer than the 6 months that after a couple. So the longer the patient is on the B cell depletion therapy, the longer, even if they stop the therapy, the B cell depletion will continue. So even if you stop fingolimod, if you stop dimethyl fumarate, if you stop teriflunomide, the effect on the B and T cells is for months to come. So even if they have an infection, you can't sort of stop it and they're coming back. It's not happening like that. So it doesn't that's why I'm saying, yeah, that's the recommendation, to do it 6 weeks before, so that you can mount an optimal response. So if you are on a B-cell therapy, you're known to not mount an optimal response, which is particularly important in COVID-19, and Ocrevus unfortunately has shown to not show as much of an immune response when you are infected than the other therapies, and therefore is probably more likely to have prolonged disease than any of the other immune suppressants.
Thank you so much, Jeannette. There's been a lot of information from both Jodi and Jeannette, and I think it's testament to the number of years they've spent in the MS space. We don't have time for any more questions. We will answer and respond to other questions offline. And I just wanted to say, thank goodness we've got a recording available on both of our websites so people can listen again, and we've got very comprehensive handouts, so that's great. So thanks to our two presenters, and Rachel and I would just like to cover very briefly the services and supports available. So we'll just be 2 minutes between Rachel and I. So I'm just going to hand over to you, Rachel, to do the Guild Ed side.
Hi everyone. Like Nicola said, thank goodness we have a recording of this one. This will be available on the Guild's learning platform, Guild Ed, in the next coming weeks, alongside 2 other webinars. One which is an overview of MS and an introduction to MS, and the other is on MS and pain management. You can also visit Guild Ed for a range of CPD approved education, online courses, webinars, podcasts and training. You can register if you're not already registered for free, and you can do so through the link that is provided in your handouts. And for those of you interested in more webinars, which is on the next slide for me, Nicola, we've also got a webinar tomorrow night through Guild Learning and Development on the next steps in the electronic prescription revolution, which is a focus on the active script list, the next step on from the token model of electronic prescriptions. If anyone is interested, you can also register for that one via Guild Ed. And now Nicola will take you through all the fantastic things that MS Australia has to offer.
Thanks, Rachel. So I just want to very quickly go through some of the services available, and I'll be super brief. Our main gateway to all of our services is through MS Connect on 1-800-042-138. Your clients and yourself can use this line. You can access nurse advisors, social workers, MS experts. We also have employment support services. That's a national service. We're an NDIS provider. We have the wonderful peer support team. We provide podcasts for clients and live webinars for clients. For our health professionals, we have a free online education service, MS Practice. We have a number of health professional webinars. We have free ebooks, webinar recordings on our shop. And you can join our newsletter so you get updated with all the webinar information. So just to finish up, a huge thank you for your time and your attention tonight. We really appreciate it. Those key numbers again, MS Connect 1-800-042-138, and our emails here. If you've got any questions from tonight, please email education@ms.org.au. And Guild Learning and Development, their helpline is 1-800-049-056, and the email is there. There's a very short, I promise you, survey after this. We'd love it if you could complete that. And thanks again for your time. Really appreciate it. Good night, and thanks to all the presenters.